Good morning. This is Stephen Grubbs, the Vice President of Clinical Affairs at the American Society of Clinical Oncology. And good morning, good afternoon, good evening, wherever you are listening and watching our webinar from. This is the ASCO Global Webinar Series titled Cancer Care Experiences and Lessons During the COVID-19 Pandemic. Today we will be covering two topics, one about laboratory diagnosis of the infection and triage, pre-screening, and screening cancer patients during this pandemic. Next slide, please. This is a series of weekly webinars that occur on Tuesday morning at 8 a.m. Eastern Time in the United States. Each session will last approximately 45 to 60 minutes, and we are scheduling sessions through May 5th. Additional sessions will be added pending the need as we move forward during this pandemic time. All of these webinars will be recorded and posted on the webinar series page, usually within 24 hours of completion of the webinar. And at the end of each presentation today, there will be an opportunity for questions and answers that you'll be able to submit to the moderator. I always remind everyone that these presentations and answers to questions about COVID-19 presented on this webinar are provided by the American Society of Clinical Oncology for voluntary informational use by providers. This information is not intended to substitute for independent professional judgment of the treating provider in the context of treating an individual patient or developing practice policies and procedures. We'll also be joined today by Mr. Douglas Pyle, who's the Vice President of ASCO International Affairs. And it's my great pleasure today to welcome Alvaro Rogado from Madrid, Spain, as our moderator. Alvaro is the Executive Director of the ECHO Foundation in Madrid. Welcome, Alvaro, and let's go to the next slide.
Thank you. Thank you very much, Steve, for your introduction, and also thank you very much to ASCO for putting in place this very interesting global series about COVID-19 and cancer that is allowing us to share experiences around the world. I would like to thank all the attendees for being here with us today. It's a great honor for me to participate in this webinar and a privilege to have these two distinguished speakers who will be sharing with us their knowledge about this topic. Each of them will have a 10-minute presentation, and then we will take a brief Q&A session after each presentation. As we will not be able to address all questions from the audience due to limited time, you are very welcome to visit the COVID-19 Resource Center at the ASCO website. I will go straight away and present our first speaker, Dr. Olivier Vandenberg. He is the lead of the new Innovation and Business Development Unit of the University Laboratory of Brussels. In addition, he is currently Professor of Microbiology in the School of Public Health in the Faculty of Medicine of the Université Libre of Brussels. You can have access to his full CV at the webinar website. The title of his presentation will be Laboratory Diagnosis of COVID-19 Infection from the Patient to the Public Health Perspective. Welcome, Dr. Vandenberg. Please go ahead.
Thank you very much, and thanks a lot for the invitation. It's a real pleasure for me to share the experience from Brussels in the control of the COVID-19 pandemic. Next slide, please. Here are my disclosures. I have no personal or financial interest to declare. I have no financial support from an industry source for the current presentation. The opinions expressed here are my own and not necessarily those of the LHUB-ULB Brussels University Laboratory. Next slide, please. The presentation outline. Over the next 10 minutes, I will present our settings, the LHUB-ULB. Next, I will discuss with you the laboratory testing for COVID-19 suspected cases with molecular methods, antibody detection methods, antigen detection methods, and I will also describe the testing algorithm for COVID-19 suspected cases. And at the end, I will discuss with you the new perspective in disease surveillance and the role of consolidated laboratories in the control of COVID-19. Next slide, please. First, our setting. The LHUB-ULB is a consolidated clinical laboratory based in Brussels, in Belgium, and we serve 5 university hospitals, 2 in the north of the Brussels region, 1 in the west, and 2 in the center part. And altogether, we perform more than 18 million analyses a year, and we serve the Jules Institute, a fully dedicated cancer institute, but also a pediatric hospital, 2 general hospitals, and 1 academic hospital. Altogether, we serve 3,000 hospital beds. Next slide, please. In our setting, our goal is to provide the same quality of result for all patients attending the 5 collaborative centers. So we have to provide an equality between sites in terms of service levels. It is why we have developed rapid diagnostic tests for COVID also in satellite laboratories. The aim of COVID-19 diagnostic and testing is first to confirm COVID-19 in symptomatic patients who present for care, first to appropriately manage suspected cases, but also to implement as soon as possible public health measures such as isolation and quarantine. The diagnostic and testing are also implemented to screen all contact of confirmed cases, and a large number of infected individuals may only have very mild symptoms or no symptoms at all, but they can still shed virus and transmit infection. So in terms of control of the spreading, it's really crucial. And we have also to test all contact of confirmed case is critical to interrupt the chain of transmission. And last but not least, we have to monitor the disease over the time just to support the control intervention in the public health level. Next slide, please. There are 3 major types of diagnostic that we can use for the pandemic response. First, the molecular test to detect the viral genetic material or RNA, serology tests to detect antibodies that patients develop in response to infection, and the antigen test to detect viral proteins. And few antigenic tests are commercially available, and we will discuss the later point more in depth. Next slide, please. On this slide, you can see the current and the most used diagnostic tools used in laboratory in most laboratories in industrialized countries. First, the nucleic acid amplification test for viral RNA, and it's mainly used to measure the current infection of SARS CoV-2, and the value is to inform individual infection status, but also to help for the management of the patient. And the beneficiary will be the patient himself, but also to support the public health measure, but also support the healthcare and healthcare worker in the hospital. And one other diagnostic tool is the antibody detection. And the antibody detection will help us to assess the past exposure to SARS CoV-2. And the value is not only to detect susceptible patients into the population, but it's also useful for patients attending the hospital 10 days after the onset of the symptoms, when the molecular diagnostic tools seems irrelevant. And the beneficiary will be the patient himself, but also in terms of population and information for the population at all. Next slide, please. When we discuss the molecular diagnostic testing for SARS CoV-2, we have to consider the specimen collection, and we have different key points to take into consideration. First, we need to have a good specimen collection, not only for the patient, but also for the healthcare worker. And what we recommend to use the nasopharyngeal swabs or oropharyngeal swabs. Sometimes saliva seems useful, or other specimens like sputum or BLA. But we have also to take into consideration the health worker performing the specimen collection, and we must underline the need to respect the biosafety measure by using gloves, but also masks and other biosafety measures. After the collection, the swabs should be placed in a viral or universal transport medium for rapid transportation to the clinical microbiology lab, ideally under refrigerated conditions. And it's really important, and currently in Belgium we have trouble in terms of the supply of transport medium, and we have to develop our own transport medium in the laboratory kitchen. Next slide, please. On this slide, you can see the molecular detection methods used in most laboratories. It's real-time RT-PCR assay. But now we have new point-of-care molecular testing, or loop-mediated isothermal amplification, and they are really useful for severely ill patients when we need to have a rapid answer for the clinical management of the patient. And next generation sequencing will be really important for the chain transmission investigation, especially when we will consider the lockdown exit program. And so in some case, we have to repeat the testing. Why? Because we can have 2 or 3 false negative results. Next slide, please. Serology is also really important in the clinical management of the patient. Sometimes at the individual level, we have PCR negative result. Why? Because the patient will attend the hospital or the healthcare center 10 days after the onset of the symptoms, and the PCR will be negative, but the serology could be useful for such patients. But be careful, we have 2 different types of serological immunoassay. We have ELISA and point-of-care test. And in our perspective, we have tested the Euroimmun ELISA, and as you can see on the control sera testing negative column, we have a specificity of 96%. So 4 to 5% of patients with no COVID infection will have antibodies, false positive antibodies, and it's a problem when we will consider the serological immunoassay to assess the seroprevalence. We have also tested several point-of-care tests from different companies, and we have good positive predictive value, but the negative predictive value is really challenging, and some tests and we have to take into consideration the quality of the test, but also from the selling company. Why? Because sometimes we have issue in terms of quality of the storage of the test, and the diagnosis test could be irrelevant in a practical perspective. Next slide, please. This slide comes from one of my colleagues. It's Pascal Mertens from a small Belgium company who developed a rapid antigenic test for COVID. And it's a really simple test. It's an immunochromatographic test. And in 15 minutes, we are able to detect the SARS CoV-2 directly from the respiratory sample, nasopharyngeal sample or BLA. Next slide, please. On this slide, you can see the clinical performance of this test, and the evaluation has been submitted to Frontiers Medicine for publication. And on a population of 328 suspected patients of SARS-CoV, we had a sensitivity of 57% and a positive specificity of 95%. So we were able to detect more than half of positive patients in less than 30 minutes from the specimen collection to the result. And in terms of patient management, it helped us to implement isolation measure, but also to order a specific drug. And in consequence, we have implemented a new algorithm, diagnostic algorithm, using the antigenic diagnostic test. Next slide, please. On this slide, you can see the diagnostic decision algorithm integrating the SARS-CoV-2 rapid antigen test. For patients with clinical suspicion of COVID-19 necessitating hospitalization, and or for healthcare workers with fever and acute respiratory infection, we first use the rapid SARS antigen test. If the result is positive, we consider that the patient is present a COVID-19 infection, and it will be the patient will be in quarantine or hospitalized and benefit of specific treatment. If the result is negative, we will do a PCR, and the PCR, according to the result of the PCR, we will either exclude the infection or confirm that the suspected patient is really infected with the SARS. And using such algorithm, we save 15% of the PCR, and we were able also to reduce the turnaround time of the result. Next slide, please. On this slide, published in the Frontiers Medicine in 2018, you can see the structure of consolidated laboratory serving different hospitals, and we have satellite lab, and we have implemented the rapid diagnostic test in the satellite lab. But we have also a central lab with a core microbiology laboratory hosting the cell culture lab, and we use cell culture for specific patient or for patient with suspected of COVID, not in terms of diagnosis, but in terms of follow-up of the viral expression. And we have also the large molecular platform. But the laboratory is also a data provider, and a data provider for the Public Health Institute. And on the right side of the slide, you may see the different connections that the lab has with the Public Health Institute, and we have developed a specific link directly with the National Public Health Institute, and we feed the National Public Health Institute with our result. And with this, the laboratory is able to support the public health measure implementation, but also act as an early warning laboratory and also help for the modelization of the disease. Last but not least, consolidated laboratories have also a role to play for the translational medicine and help the manufacturer or the academic partner to develop new diagnostic tests, either by providing sample through the biobank, but also by validating the new and helpful diagnostic tools. So the laboratory has a role to play not only at the individual level, but also in terms of public health and translational medicine. Next slide, please. Before to end this slide and to answer the different questions, I would like to thank all of my colleagues involved in the COVID diagnosis and control. And if you have any question or any request for information, do not hesitate to send me a mail at the following address, olivier.vandenberg@lhub-ulb.be. Thanks a lot for your attention, and thanks again for the invitation to share the experience from Brussels. Thank you very much.
Thank you, Dr. Vandenberg, for your great presentation. Now we have some minutes for some question and answers. I will go for some of the questions from the audience, and here I have one that says, could PCR results be affected if the sample is not transported refrigerated?
Yes, we have seen that a good specimen collection, but also transfer, especially if we have high temperature or desiccation, will impact the result of the PCR. We have also seen that some transport media are not useful, have an impact on the result of the antigenic diagnostic test. So we have tested the transport media from Copan, and we have a good result for the universal transport media. The homemade is also useful, but when we use AMIES, we think that we have observed that the antigenic diagnostic test result was impacted by the transport media, and also by storage, the transport condition in terms of temperature.
Thank you. Another question we have is, in your opinion, what is the most adequate sample, oropharyngeal or nasopharyngeal, to diagnose the COVID-19 infection? In my perspective, we recommend the nasopharyngeal swabs, but sometimes the patient complain in terms of pain when we do the specimen collection. And what we have, due to the shortage in terms of specimen, in terms of swabs, what we have done, we also use the urethral swabs, generally used for STI diagnosis. So we use the urethral swabs in combination with the homemade culture transport medium. Thank you again. One more question. We have time for this. At what time are serologies recommended to be performed to identify already cured patients? What we have seen is that after 10 to 12 days, we have nearly 100% of positive antibodies. But it's the presence of antibodies is not
neutralizing antibodies. We have also to develop neutralizing antibodies assay. I know that several companies are working on this. We are currently evaluating the Diasorin diagnostic test. I know that Roche will also develop a new diagnostic test, antibodies diagnostic test combining IgA, IgM, and IgG, but we are waiting for the kit to do the validation.
Okay, I think we have time for one more. When the test is negative, when do you recommend to proceed with a PCR test?
In Belgium, we recommend to perform two. If the PCR is negative, let's see. When we have a suspected patient, what we do in a routine perspective, we do a CT scan and also the PCR diagnostic algorithm. So first we do the antigen test, and if negative, we do the PCR. And if the PCR is negative and the CT scan and the clinical history is compatible with SARS CoV, we will do a second PCR. If needed for the severely ill patient hospitalized in the ICU, we may do a third PCR from deep specimen such as the BLA, bronchoalveolar lavage.
Okay, one more question for you. What is the value of immunoglobulin A? The person is asking that immunoglobulin G and M is clear, but what do you think is the added value for IgA in this case?
When we tested the Euroimmun test, we have IgA and IgG, and we have compared the result with another ELISA testing IgM and IgG, and what we observed that we had the same kinetic for IgA and IgM, but it seems that the IgA seems more specific, but it's just in a small number of specimens.
All right, and this is the last question. We have time for it. Could a positive PCR in a patient later than 30 days after the initial diagnosis in bronchoalveolar lavage mean a reinfection, or can it remain positive for that long?
It's a difficult question because it could be a reinfection, but what the infectious disease specialists also underline, we could also just amplify the RNA and without any significance. It's not clearly a live organism. So it's debated, and what we do, for the quarantine and the measure, we consider that we need to have 2 negative PCR before to stop the quarantine and isolation measure. But it's debated what is the significance of a positive result after 13 days.
All right. Thank you very much, Dr. Vandenberg, for your participation, also for the job you are performing in your country. And thank you for participating in this global webinar series organized by ASCO. Thank you very much. Now
Thanks again for the invitation.
Thank you. Now it's time to introduce our second great speaker. Her name is Dr. Jeeyun Lee. She is an associate professor in the Division of Hematology and Oncology at the Samsung Medical Center in Seoul, Korea. Dr. Lee specializes in gastric cancer, colorectal cancer, sarcoma, and melanoma. you can have access to her full CD at the webinar website. She will be talking to us about her experience in Korea, a country which has been very successful in its fight against COVID-19. And the title for her talk will be Triaging, Prescreening, and Screening Oncology Patients for COVID-19, the Samsung Medical Center Experience in Korea. Welcome, and thank you, Dr. Lee, for being here with us.
Hi, thank you for giving me this opportunity to share our experience with COVID-19 as an oncologist. Can you give me the next slide, please? So in this presentation, I will briefly go over the current status of COVID-19 outbreak in Korea, how we are keeping our cancer center free from COVID-19 to provide optimum care for oncology patients, briefly go over our outpatient and inpatient screening protocols for oncology patients at our center. And lastly, I will briefly go over how we work with IT-based surveillance efforts, which reflect the governmental posting of contaminated areas, including hospitals, restaurants, churches, different regions of the country in a high-volume cancer center. Next slide, please. So we had the first case of COVID-19 confirmed within our country back in January 20th. She was a visitor from Wuhan, China. And if you look at the graph here, we had some slow increase in COVID-19 positive patients since January 20th, but starting in February 20th, we start to see an increase in number. And by the time we have 400 patients or 500 patients confirmed of COVID-19, this is where the government issued a red level alarm throughout the nation, so that all schools are closed. Nationwide social distancing has been ordered, but it is it is without mandatory closing of public areas like shopping malls and restaurants. So since then, we are keeping this red level, and from February 20th to about March 16th, for a month, we saw a steep curve, and then the curve started to plateau off. And as of April 16, we are seeing 20 to 30 new cases per day, with a total of about 10,000 patients so far. Next slide, please. So since the first patient who was diagnosed on January 20th, 12 to 13 days, we had some darkness for testing our patients for COVID-19, because it was a central CDC designated laboratory in our country who are testing all suspected cases in the country. So we sent the clinical specimens to the central laboratory, and the turnaround time was 48 hours. But on February 4th, the Korean government issued an approval for local RT-PCR COVID-19 testing that can be used in all hospitals. So patient will pay about $100 per test if it is ordered outside of national guidelines, or patient pays less than $50 the test is reimbursed by the system. On February 7th, this is when the RT-PCR COVID-19 tests became available nationwide in all hospitals who have laboratory medicine departments. So at SMC, we started testing for COVID-19 since February 7th. The turnaround time is 6 hours for the laboratory medicine. They are testing 4 rounds per day, and we are testing about 200 tests for surveillance purpose at SMC each day. So for your reference, you can look at the table. We have tested about 500,000 patients plus since January 20th, 2% positivity of all tests that were carried out. And the percent positivity is actually going down because we test more patients and less patients are getting COVID-19 positivity. Next slide, please. So if anyone wants to get a COVID-19 test for various reasons, they could call the central call system. Then the call system guides you to nearby test centers. We have 71 drive-through centers and 580 centers that could do COVID-19 RT-PCR tests. Average turnaround time for nationwide system is 1 day. We have less turnaround time for our hospital because we see different kinds of patients and we need to see the test results to keep free of COVID-19. If the patient is COVID-19 positive, then patients are referred to CDC-designated COVID-19 hospitals. Next slide, please. So for SMC, it's one of the big centers in Korea. We have 2,000 in-beds, 9,000 outpatient visits per day. We give 500 to 600 chemotherapy each day. So we try to maintain this activity without interrupting necessary chemotherapy or clinical trial visits in this pandemic time. So the essential role has been provided by the centralized Korean CDC, who shares information with centralized infection control center at our center for pandemic control. So basically, oncology patients and oncology faculties are actually following essentially control tower here, which aligns with the government CDC. Next slide, please. So for outpatients, basically, we try to do COVID testing before the suspected patient enters the hospital. So the powerful part was to have pre-screening team here so they could call in all the scheduled patients for outpatients to survey epicenter visits, any contact information, any contact possibility with COVID-19 positive patients. And we do pre-visit phone calls, and also we send out apps and web links to patients' phones so that they could turn in. And if they need COVID-19 tests, then they are referred to one of the drive-thrus or nation designated centers, and they bring the COVID-19 results with them while they visit our outpatients. If the patient comes in for outpatient visit for various reasons for oncology symptoms and not tested for COVID-19, then the patient is referred to outdoor triage center at our hospital or ER triage center so that they could get COVID-19 testing at our hospital and 6 hours quarantine. And if the test results are negative, then we treat oncology patients as we do normally in the non-pandemic period. Next slide, please. For inpatients, this is where we are very nervous about because we have 200 patients admitted to the ward, and the number has only decreased by 10% for during this pandemic period. So we just need one asymptomatic spreader to get all infected. So we do pre-admission apps, web link surveys. They get SMS text to do pre-visit surveying for contact tracing information that is posted by national CDC. And when the patient is admitted, we do random, rigorous inpatient COVID-19 surveillance. All febrile patients will get, or any X-ray abnormalities will get COVID-19 testing again, even the patient was tested for COVID-19 before admission. So, and we have a multiple alarming system with radiologists who see all the X-rays, CTs taken at our center so that they could call in our infection control tower so the inpatient who might have COVID-19 while they were admitted can be tested for COVID-19. Next slide, please. Next slide, please. Okay, so it's a big hospital, so we don't, physicians, nurses, we are alert about COVID-19, but there are another 1,000 staff who are not medical staff working at hospitals, so we have incorporated all the COVID surveys, risk factors that have been collected, and we have reflected into our medical information system, so everyone's seeing the same page, and the survey links are updated every day, essentially every day, so that it reflects all the epicenter and contaminated areas of the country. Next slide, please. So because it's a large hospital, we are, we had experience with MERS outbreak back in 2015, and we learned that it is very important to control inflowing patients as well as controlling medical staff, including administrative staff, so that no one's exposed to COVID-19 or viral outbreak. So we do rigorous app-based questionnaire twice a day since January 29th. So it's a self-symptom check for every personnel who works at a hospital, whether you're medical, non-medical, or part-time, or full-time, everyone. And mobile online questionnaire for visits that reflect real-time outbreak areas that is posted by government once daily. So every time there's an outbreak, for instance, there was an outbreak at the Opera House, then everyone in our hospital will get a mobile survey whether we have visited that Opera House. And if you have contact, then we are indicated for COVID-19 testing. Next slide, please. So in summary, to keep our hospital free of COVID-19, we do multi-layer with the help of IT department and text messages surveillance system, which reflects all contaminated area in the country that aligns with Korean CDC postings every day. So we prevent inflow into the hospital. I think one of the ways to do this was to do an over-testing. We are still testing over 200 patients per day, and so far, luckily, we didn't have any COVID-19 outbreak in oncology wards or outpatients so far. So with this pandemic, I think what we learned is we are connected globally more than we have realized before. Thank you.
Thank you. Thank you, Dr. Lee, for your presentation, for sharing your experience, and also I have to say congratulations, because it is unbelievable the way that you have been able to manage the situation in your country, and I think it's a great example for all of us in other countries. Before addressing questions for the audience, I would like to ask Dr. Vandenberg to comment briefly about Dr. Lee's presentation. Dr. Vandenberg, would you like to add your comments, please?
Yes. First, I am really impressed by the work done, and you represent the goal that we have to achieve in European countries. It's really impressive. Thanks for what you did. I have a specific question. What are your recommendations in terms of lockdown exit strategy about the integration of seroprevalence and also the track and destroy patient in terms of the what you recommend to combine seroprevalence and PCR, or only PCR and so on, because some countries are looking for the combination of antigenic test and PCR, as recently published in the Lancet Infectious Disease for UK. What are the main recommendations? Thanks.
Yeah. So right. I'm a clinician. I just do whatever laboratory medicine set up for. But based on our experience, we do RT-PCR with nasopharyngeal and oropharyngeal specimens. We tend to do both. We don't have any experience with other testing yet, but we'll be very interested to see if that increases the detection rate of COVID-19 in our community. But so far, the local testing has been the RT-PCR COVID-19 test.
Okay, thank you very much.
All right, thank you, Dr. Vandenberg. I have some questions from the audience. There is one question that is talking about hospital staff, and it says that, Dr. Lee, when you mentioned about hospital staff wearing a mask for the protection, what kind of mask are you referring? Surgical, FP? As you know, in some countries, we have been suffering a lack of this equipment. So what is your recommendation, and what do you refer with this?
Yeah, so the recommendation from our infection control tower at our hospital is the surgical mask for all, so everyone, including patients, families, medical staffs, and non-medical staffs at our hospital. So basically, everyone's wearing surgical masks. And for high-risk physicians, we wear N94 mask. So I think the general guideline here is to wear surgical masks for everyone who's in the hospital.
Okay,
and
thank you.
Yeah, thank you. And we also do random mask rounding by the leadership. So the leadership, infection control tower leadership, will do random rounding every day to different wards so that everyone's wearing surgical masks at least, including families.
Okay, thank you. We have some comments also from the audience saying that it's a true demonstration of how to respond to the epidemic. So it's just not a question, but some comments about saying about your experience, and say congratulations to you for the way that you have performed this. Also, we have some other questions that says how the oncology treatment differ from COVID-19 positive non-symptomatic patients. It's important to know from your experience how you address the oncology treatment for patients with COVID-19.
Right. So far, we have zero experience with COVID-19 positive oncology patients because if the patient is coming from epicenter, then all the visits were delayed, postponed for 2 weeks. Mm-hmm. And after 2 weeks, then we ask them to bring COVID-19 negative test results with them when they visit us. So by the time they see oncologists, the patients are COVID-19 negative. So I don't have any experience with COVID positive patients yet.
Okay. Another question is, do you recommend to the oncology patient at risk to be locked up?
Oh, locked up. Yeah. Actually, the number for us is that, it's not a highly recommended procedure for oncology patients, of whom 20% of oncology patients already have depression, underlying depression, fighting for their disease. But lockdown is very important. So when we discharge our patients, we educate multiple times for our patients that they stay home only until they come to, two weeks later chemotherapy. So yes, I think I'm supportive of lockdown of oncology patients, except for visiting us for chemotherapy.
Yeah. Another question from the audience says, how do you anticipate the confinement in South Korea? Your percentage of immunized people seems very low. Is that a challenge for this?
Oh, immunity. Yeah, I think we are expecting. Again, I'm not an infectionist, but I think it is general idea among physicians that we'll see a second peak in the fall. So we have to prepare for a hard hit in September because we are not immunized yet, but we'll have to see.
Yeah. Another question I would like to ask you is how is this affecting the clinical trials in your medical center?
Right. So for clinical trials, we have filed with MFDS, equivalent to US FDA, that if you are clinical trial patients and you must come, but you're from epicenter, like Daegu in Korea, then they allow us to delay the scheduled visit without major violation. But we had to file with IRB that we are going to do that.
Okay. And have you seen any difference in terms of the type of treatment the cancer patients with COVID-19 could be receiving in terms of chemotherapy, biologic agents, immunotherapy? What is your experience and what can you share with the audience about the type of treatment in these cases?
Right. So I think towards the end of February and end of March, when we had a peak, we had like 200, 300 patients per day. That was when we lowered the clinical trial enrollment rate, make sure that we are not, putting our patients at risk because, we might have, we didn't expect to have that plateau by April. So the clinical enrollment rate has gone down slightly during that pandemic period, but now it's starting to pick up. But we are still very anxious about it. So we are trying to be on conservative side.
Okay. Although it seems you have been able to control very well the situation, I would like to ask you about the health professionals' psychological impact, and if you have seen any type of impact during this time, or how are you trying to prevent a possible burnout of this professional health people? Sorry.
Yeah, I think it's going to be a big problem for every medical professional globally. We are seeing less cases now, but we are as anxious as everyone else is because from the MERS outbreak back in 2015, what we learned is that we just needed one asymptomatic super spreader who could cause hospital transmission within a week. So everyone's very anxious. The anxiety level is really high. As coping with cancer treatment, I think the best way is to talk to each other that we are stressed, and I think that's the best way of coping with this kind of stress level because I think it's going to be there for months, realistically.
Yeah. Yeah. Okay, I think we have time for the last question. I have a question for the audience saying that in terms of protection and masks for the people and for public, they are asking if the masks are provided by the government, or is suggested that people make their own mask like in other countries, or buy their own at the pharmacies. How is the situation for protection in the people in your country now, in Korea?
Yeah. So since the alarm level was escalated to red in February 23rd, what the government did was they bought all the masks, and they had a distribution plan at the private pharmacies to everyone. So government is actually controlling the masks so that they're not selling it out to other non-needed areas for commercial purpose. So basically, we are, and I think for Korea, one difference is that we love masks, even in the non-pandemic time. So don't feel bad about it, because we have bad air and we just hate it. So we were used to wearing masks during this period of time in April, and because of that, we have many mask factories to make masks. But when the time came, the government took control over selling masks so that everyone gets an even number of needed masks.
Okay, thank you very much, Dr. Lee. Thank you for being here and sharing your experience. I just wanted to thank you both speakers for the great contribution to this global webinar series. And also would like to remind all the attendees that you can visit the ASCO COVID-19 Resource Center for any questions that we have not been able to address during this conference due to lack of time. Now I would like to hand over to Dr. Pyle for the wrap-up and conclusions.
Great, thank you, Alvaro. And like you, I'd just like to thank Dr. Vandenberg and Dr. Lee for their excellent contributions on this webinar. We've learned so much, and Dr. Lee, as you said, we are truly more global than we realize. And we may be adopting practices such as wearing masks more universally, as you suggested. So thank you for all of your contributions. Alvaro, thank you for leading us in this conversation so ably. Thank you for all the participants for your participation and your excellent questions, excellent discussion. Thank you. I'm sorry, please be sure to attend the next webinar, which is on April 28th. That's the same time, 8 o'clock. And also be sure to continue to check the ASCO website for updated COVID-19 resources from ASCO. And please take care and stay safe. And thank you once again for joining us today. Thank you.